Dr. Arun. All yours, Dr. Arun Kedia.
So, good afternoon to all. First of all, I assure that I won't be as fast as Dr. Alok Modi. I'll go very slow, and I'll convey the right message so that we understand what I'm actually trying to convey through this double trouble. So here I'm not going to talk on rheumatoid arthritis per se, because the conference is concentrated on diabetes. But keeping rheumatoid arthritis as a background, I would like to define diabetes not only just as a metabolic disorder, but as an immunometabolic disorder. So there is a new term called as immunometabolism, and that is how the new definition of type 2 diabetes is coming up for the future. So all these years, we know that metformin helps only in preventing the progression from pre-diabetes to diabetes, but doesn't prevent you from any complications. Recently, we have had two drugs, GLP-1 receptor agonist and the SGLT2 inhibitors, which actually target the complications of diabetes. But as such, we do not have any drug right now to target at the immunometabolic dysfunction that occurs in diabetes, except the pioglitazone, which targets the metabolism. So double trouble, because you have immune dysfunction and you have a metabolic dysfunction, and that is what we need to understand. So to set the background, we know that rheumatoid arthritis is a chronic autoimmune condition characterized by persistent synovial inflammation. And this inflammation is the background on which the diabetes will also be defined. And here you have irreversible cartilage and bone damage. There are osteoarticular manifestations, but more important, the dangerous ones are the extra-articular manifestations, and one among them is the metabolic syndrome and cardiovascular disease. And there is an increasing evidence which suggests that RA patients are more susceptible to diabetes mellitus, and rather, rheumatoid arthritis aggravates the metabolic disorders in diabetes patients, indicating a close association between rheumatoid arthritis and diabetes. So the global prevalence of RA is estimated to be somewhere around 1%, as against what we see for diabetes, which is around 10 to 11%. The prevalence of RA is between 3rd to 5th decade of life, more in females. But what is important is that because it is an inflammatory disorder, there are a lot of inflammatory pathways which are involved in the pathogenesis of rheumatoid arthritis. And these are something which are common also in the pathogenesis of diabetes, and that is what I'll come to. Now, coming to the epidemiology of RA with diabetes, so approximately 20% of RA patients have diabetes as a comorbidity, and a large number of RA patients might have insulin resistance, which are undiagnosed because there is no guidelines which tell that all RA patients should be screened for pre-diabetes and diabetes. So definitely RA is linked to a higher prevalence of diabetes development. So the link between the two diseases is very strong, and the basis for this link is not only inflammation, but the immobility, which is characteristic feature of acute rheumatoid arthritis, and even chronic rheumatoid arthritis, which prevents patients from mobility and thereby leading to obesity. Then there are drugs like glucocorticoids, which are used in rheumatoid arthritis to suppress the inflammation, which can cause diabetogenesis. Of course, depression is a common link between both diabetes and arthritis. And then there are some common risk factors which are there common for both diabetes and rheumatoid arthritis. And these common risk factors are the male patients, especially when you have diabetes and rheumatoid arthritis at an advanced age. Then you have obesity, smoking, then some genetic and environmental factors, and low socioeconomic status, again, is a risk factor for both rheumatoid arthritis as well as diabetes. So keeping all these factors in mind, there has to be a link which connects both the diseases, and this link is basically the sinister link. Why I call sinister? Because rheumatoid arthritis, we know, is associated with cardiovascular diseases. At the same time, we have learned that insulin resistance and diabetes have an increased CV risk. So now if you have diabetes with rheumatoid arthritis, then the probability of cardiovascular diseases is increased much more than when you have a single disease. So the link between the two diseases is inflammation, And we have already learned that type 1 diabetes is an autoimmune condition where, again, inflammation is there. But type 2 diabetes is also considered as a disease of chronic inflammation. And this chronic inflammation begins at the level of adipose tissue. Why adipose tissue? Because from the from the twin cycle hypothesis, we have learned that when you have calorie excess, then these calories are converted into fat, it's deposited in the liver, and whatever the extra fat is spilled, and it gets deposited into the pancreas. Now, this adipose tissue is a very, very inflammatory sort of soil for inflammation, and it generates a lot of adipokines and cytokines. And these cytokines then in turn stimulate the macrophages. The macrophages convert from anti-inflammatory to pro-inflammatory, and that's how this cascade of inflammation begins. And these are characterized by the presence of acute phase reactants in diabetes patients, including increased levels of fibrinogen, C-reactive protein, interleukins, plasminogen activator inhibitor, and so on. So we have a definite role of inflammation in type 1 diabetes, as we have already learned, and even Dr. Vasant Kumar sir has already emphasized on it, that there is an immune dysfunction leading to autoimmunity and persistent inflammation leading to ultimately the beta cell destruction. But what is important is to realize that inflammation also plays a very important role in the pathophysiology of type 2 diabetes. And I said that adipose tissue is the mother of inflammation. And these adipose tissues, when they secrete these cytokines, what they create is an environment of inflammasome. The NLP3 receptors take over, and there is IL-1 beta signaling. And this IL-1 beta signaling has been found to be very high in patients with type 2 diabetes, especially if they have associated obesity. So inflammation definitely has a role in pathophysiology of type 2 diabetes. And once type 2 diabetes develops, these patients, because of destruction of beta cells in the pancreas, persistent hyperglycemia, persistent elevation of reactive oxygen species, lead to further inflammation. So the patient gets bound into a vicious cycle of inflammation, leading to further beta cell destruction, leading to further hyperglycemia, lipolysis, increased fatty liver, and so on, all the different insulin resistance tissues coming up, and inflammation taking place in all the other insulin sensitive tissues. So there is a definitive diabetogenesis in rheumatoid arthritis. Apart from the role of inflammation, we also have drugs, especially the glucocorticoids, which cause insulin resistant state. And these lead to beta cell overcompensation, ultimately leading to premature prediabetes and then premature diabetes. So patients with rheumatoid arthritis are prone to develop diabetes much earlier than patients who are not suffering from rheumatoid arthritis. So as I've already told, the factors involved in the link between rheumatoid arthritis and diabetes are not only inflammation, but the other environmental factors in the form of immobility and the drugs that are used to treat rheumatoid arthritis. So rheumatoid arthritis leads also to inflammatory, hyperinflammatory condition and ultimately insulin resistance. So a lot of patients who do not develop diabetes but might have insulin resistance, and there we need to screen them to find out which patients are high risk to develop future diabetes, and accordingly we should involve the precision medicine to treat rheumatoid arthritis. And similarly, in the future we'll have precision medicine to treat even diabetes mellitus. So diabetes, rheumatoid arthritis is connected with insulin resistance at the level of joints, causing increased release of cytokines, at the level of liver by causing fatty liver, and then at adipose tissue and as well as skeletal muscle, leading to sarcopenia and thereby increasing insulin resistance. So insulin resistance is another important feature which is present in patients with rheumatoid arthritis, and this can lead to development of type 2 diabetes. So do we have clinical evidence? Do we have studies? Of course, yes. There is a study which has shown that type 1 diabetes patients have approximately 2.8% incidence of total rheumatoid arthritis. At the same time, there's a high prevalence of type 2 diabetes also in patients with rheumatoid arthritis, and studies have shown that it may range from 10% to 20%. In fact, there are different studies done and they have shown a very heterogeneous incidence. It is probably because a lot of rheumatoid patients have never undergone screening for pre-diabetes and diabetes, and probably that is why a few studies show a lower incidence. So this was a recent meta-analysis published which showed a relationship between rheumatoid arthritis and diabetes mellitus. So here the search was done, and 3,000 plus articles were searched. Of these 5 journal articles, 2 conference abstracts were finally selected, representing 16 lakh patients. And what they found that the relative risk of diabetes in patients with rheumatoid arthritis, the pooled relative risk was 1.23. And so the study confirmed that there is a strong association between rheumatoid arthritis and diabetes, which confirms that probably inflammation plays a lot of role in the generation of diabetes. Now coming to the effect of treatment of rheumatoid arthritis on insulin resistance. So majority of the drugs that we are using today for rheumatoid arthritis have shown to decrease insulin resistance, except for glucocorticoids. Now, glucocorticoids initially were used very rampantly in patients of rheumatoid arthritis, and it has been found that if you use glucocorticoids for a very short duration, then the patients are not at risk of developing diabetes. But when the patients are on chronic glucocorticoid exposure, even in small doses, then these patients are prone to develop prediabetes and diabetes. So except for glucocorticoids, if you see all the drugs that are used in patients with rheumatoid arthritis, they actually reduce insulin resistance, they decrease HbA1c, and they decrease the risk of diabetes. And that is why the focus on treating rheumatoid arthritis has now shifted more into biological therapy, more into targeted therapy, targeting the inflammation rather than trying to just suppress the inflammation with the help of glucocorticoids. And that is where the biologic drugs have come up. And probably there's a lot of research going on in the field of diabetes, and maybe in a few years we'll have some biological therapies coming up for the treatment of type 2 diabetes also. So there is research going on for developing IL-1 receptor antagonists. There are some studies going on blocking TNF-alpha. There are studies going on inhibiting IL-6 also. And probably these drugs might be the future for treating inflammation in type 2 diabetes. They are actually trying to remove the entire soil of inflammation, which generates the cytokine storm in patients with morbid obesity and leads to insulin resistance and type 2 diabetes. So these are the mechanisms by which glucocorticoids induce diabetes, and we all know that they work at the level of not only adipose tissue, but also reduce insulin sensitivity at the level of skeletal muscle as well as liver. And that is why the guidelines say that try to use glucocorticoids for a very short duration, and if at all you have to use, try to use it in a very, very small dose. But as early as possible, we need to taper it off. So how do we manage type 2 diabetes with rheumatoid arthritis? It needs a collaborative care. We need to emphasize on lifestyle modifications because the common risk factors of immobility, inactivity, physical inactivity, dietary interventions, they are common for both diabetes as well as rheumatoid arthritis. And in one of the previous lectures, which Dr. Merchant was talking about, where he emphasized about the diet in reducing psychiatric issues, the diet is also important to reduce the inflammation. It has been found that if you have a very high dense calorie diet, then there is a pro-inflammatory state at the level of intestine as well as the adipose tissue. Medication management has to be done in collaboration with rheumatologists, but the principle is to hit the inflammation at the earliest and reduce and try to avoid using glucocorticoids. And we need to regularly monitor these patients for development from pre-diabetes to diabetes or for developing the further cardiovascular disease because the majority of these patients actually die from cardiovascular disease. So coming to the conclusion, the link between rheumatoid arthritis and diabetes is one and only inflammation. And probably we need to look at diabetes not only from metabolic angle, but also from immunological and inflammatory angle, independent of BMI or specific RA therapy, such as the use of glucocorticoids, higher baseline activity, and elevated levels of pro-inflammatory markers like IL-1, IL-6, TNF-alpha, they have shown to have correlation with higher risk of diabetes, and that is where we actually conclude that probably diabetes is an inflammatory disorder, and that is why in patients with rheumatoid arthritis, wherever we have to treat diabetes, we must ensure that the patients have a low disease activity, we need to target inflammation rather than trying to jump off into treatment of diabetes before trying to suppress the inflammation in patients with rheumatoid arthritis. So with this, I thank you and I give you the thoughts on thinking further diabetes as more of an inflammatory disorder rather than just a simple metabolic disorder. Thank you.
3 cheers to you for finishing on time.
Thank you, ma'am.
And a wonderful lecture. Thank you so much.
Thank you, ma'am.
Yeah, it was not only, just, we know that rheumatoid arthritis is a chronic disease and diabetes also, but we have linked the both so well. And even for me today, for the first time, I realized that both of them have insulin resistance.
So I think we should thank the organizers for actually trying to present this topic. And Dr. Faraz actually probably very intelligently pushed this topic towards me because he didn't want me to speak on rheumatoid arthritis, but rather he wanted me to highlight that diabetes is an inflammatory disorder.
Yes. Thank you. Thank you. Any questions, please, from the audience? Yeah. Dr. Alok, speak slowly. Mike?
How do you approach such people?
So,
or people who have RA, but then we have a pre-diabetes kind of condition. Because this is something, what you're saying is very right. But what I'm interested in is how do you approach such patients thinking what will happen after 5 years?
So when you have a patient with diabetes who comes with a joint pain, you need to rule out few things, whether it is an inflammatory joint pain or it is a non-inflammatory joint pain. Inflammatory joint pain would be characterized by early morning stiffness. That is the most important thing that the patient will tell you. And secondly, the patient will improve with activity and he will deteriorate with rest. As against the mechanical joint pains, where the patient will improve with rest and will have more pain during activity. So the most important thing is to differentiate between the inflammatory versus non-inflammatory joint pain. If it is an inflammatory joint pain, then you have to treat with biologics or anti-inflammatory agents. But if it is a non-inflammatory pain, if it is a mechanical pain, then probably you have to treat with NSAIDs. So that is number one. Number two, you must try to give them a relief from joint pain by giving drugs, by promoting physiotherapy, and by promoting physical exercise also. Because a majority of these patients, once they develop pain, they are advised to take complete rest. And rest means they will develop obesity. So physical activity must be promoted even in patients with arthritis after controlling the pathogenesis of that particular joint pain. Is that what you wanted?
I was looking at a little something different in the sense that I'm not looking at the therapeutics. So somebody comes with mild joint pain, not interested. He doesn't need therapy. He's comfortable. He's doing his daily activities very comfortably. But I'm looking at it since it's a common inflammatory pathway. Both are inflammation. Like, now we look at pre-diabetes, pre-hypertension, and we start actively working so that they don't land up in trouble tomorrow. So similarly, if somebody comes, my diabetes for 10 years, I started complaining of joint pains, vitamin D is normal, RA is negative. How do I approach this patient? What should I think in the future after listening to you? I need to take it a little more seriously, right? Rather than wait for him to develop proper arthritis as an inflammatory because of... So something, is there any work, any molecule or what you said, just make them exercise very well and get rid of the obesity, the standard approach, or something else?
So your question probably will be answered in the future. But what at present I can say is, when you have a patient who comes with early joint pains, you need to see through a high index of suspicion whether this patient is likely to develop inflammatory joint pain or a non-inflammatory joint pain. Now, if you do not have RA factor which is coming out to be negative, remember that RA factor negative may not be negative forever. The patient may develop seropositivity a few years later or maybe a few months later. Now, that is where there is an entity called as preclinical RA now, where again the patient might have RA factor positivity but might not have joint pain right now. So you might come across both the situations, but what we need to do is a close follow-up of all these patients. That is what I would suggest at this point of time.
You said type 1 and rheumatoid arthritis is related. I mean, about 2.8% you said?
2.8%.
Yeah, 2.8. Dr. Vasant, do you have you come across type 1 disease with rheumatoid arthritis in your so many patients? Yeah, both are autoimmune.
So if I have to answer this part of yours, ma'am, I have a pool of 53 type 1 patients, and out of which one female is suffering from rheumatoid arthritis, and she is at the age of 17 as of today. And she developed inflammatory joint pain right at the age of 15, and she was diagnosed with rheumatoid arthritis at a later age, because people didn't think of rheumatoid arthritis for a 15-year-old girl. Yeah, Still's disease is common, but again, we don't have data of Still's disease with type 1 diabetes as of today. We don't have any data. We have data, very small data on type 1 diabetes with rheumatoid arthritis, but no extensive data on this. Probably it is not very common.
Yeah, any other questions from the audience?
So I think we are deviating from the conference. My idea was not to talk on rheumatoid arthritis, but I kept rheumatoid arthritis as a background to convey the message that diabetes is an inflammatory disorder. But coming back to your point, at what stage he wants to know that we need to put on patients on biologics in RA. Patients who are not responding to conventional synthetic DMARDs will have to go on biologics. Second, if the patient has a very high disease activity, not responding to any of the conventional DMARDs, or he responds to steroids, but he relapses as soon as you start tapering the steroids, then probably you will have to put the patients onto biologics or targeted synthetic DMARDs.
The last question, with the permission of the chair.
Hello, sir. One question. Most of the diabetic patients are obese. They have metabolic syndromes. Most of them, they have osteoarthritis because of age. Now, how it is wise to put this patient on NSAIDs instead of paracetamol plain? Thank you.
Sir, if you have to treat osteoarthritis with paracetamol, you need to give a higher dose of paracetamol. They will not respond to the conventional 500 milligrams. Most of the time, we need to treat them with 1 grams twice a day, or sometimes even 1 grams thrice a day, if you have to treat with only paracetamol. Now, patients who respond to paracetamol, you can continue them on paracetamol, but at the same time, you must ask them to go for physiotherapy. Because one of the reasons why osteoarthritis does not respond to NSAIDs or paracetamol is the muscle dysfunction. And majority of the patients, because of disuse of that particular joint, develop muscle weakness or sarcopenia. So with physiotherapy, we need to develop the strength of these muscles, and the joint gets aligned again. And a large number of patients can be tapered off from NSAIDs or paracetamol and can lead a normal life without drugs.
Yes, sir. Lifestyle modification and
And we also need to teach them about the harmful effects of steroids, because a large number of patients are otherwise prescribed steroids by some other doctors, and their patients get an instant relief, and then they feel that this is a magic drug.
And that again gives rise to hematemesis and melanoma and all the gastritis and all these things. Thanks.
Sir, do you foresee the resurgence of HCQ? Because essentially, even earlier, HCQ was used as anti-diabetic medications. With this combination, do you foresee a resurgence of HCQ, especially as a sort of a prophylaxis?
See, HCQ has to be given in all patients of rheumatoid arthritis unless until there is a contraindication.
No, in a combination of a preclinical RA and diabetes.
There is no such data. HCQ does not prevent progression of preclinical RA to RA. That is number one. So prophylaxis has no use. That's what the literature says. Coming to its use in diabetes, it's a very, very weak anti-diabetic agent, and the HbA1c reduction is only 0.2 to 0.3%. So if your patient is a pre-diabetic with some preclinical features of RA, then probably you might use HCQ for treating both the conditions. But otherwise, majority of the patients who come to our clinics usually do not come in a very preclinical stage. They come with florid symptoms only. So we hardly get chance to treat with very early disease.
With this, we close this session. I thank all the speakers, Dr. Arun, Dr. Vasant Kumar, Dr. Alok, and Dr. Parag. I invite all the speakers to the dais, please, for the mementos. No?
There's a small correction, ma'am.
Okay.
Chairpersons and the speakers, they will be felicitated near the selfie booth.
Okay.
So all the chairpersons
Sorry, I didn't know that.
and the seekers of diabetes and complications are requested to please gather at selfie booth. Okay. By the way, it was a very good session, and especially Dr. Alok, the AI. Short story, sir. Recently, last month, I published 2 articles using AI. So I thought even only I use it, like people of my generation use it to shorten our time. But it's really good to see like professionals using it. Thank you. Thank you for the insights. Thank you, sir. So moving on to our next session, Cardio-Renal Symposium. So I would like to call on the stage Dr. Shaista Hussaini. Dr. Shaista Hussaini, Dr. Pinajala Ramakrishna, Dr. Amrendra Singh, Dr. Anuj Kapadia, Dr. P. Sirath, to please gather on the stage. Over to you, sir.
Thank you for this interesting, we'll start this interesting session on cardio-renal symposium. Metabolic, as you know, around 40 to 50% of patients of coronary artery disease have diabetes. Many of them have renal failure. And a lot of drugs, what are started as anti-diabetic drugs has been taken over by the cardiologist as a first-line treatment for as cardiac drugs. With this, let's start the first speaker. Let me introduce
Dr. Manjusha, kindly take over, please. Thank you.
Thank you so much. It's been a proud privilege to be here as a speaker on this, in this August session. I thank Dr. Farishta for inviting me for this talk. Thank you so much. So after a good conversation on complications in diabetes, we move on to the next entity, that is cardio-renal syndrome. So my talk is on time to act on one particular drug, that's the finerenone. Finerenone apparently is supposed to be the pillar of treatment in type 2 diabetes. So these are my credentials. Outline of my talk is going to be on background and literature, clinical trials, the guidelines, and the practical aspects. As we all know, chronic kidney disease in type 2 diabetes is a very large, growing problem leading to end-stage renal disease, atherosclerotic cardiovascular disease, as well as heart failure. Milieu, though a little schematic algorithm is there, we need to understand that the milieu of the diabetes as the high glucose and the glucose-derived products are going to have an impact, significant impact on the kidney, whether it is the glomerular cells or whether it's the tubular cells, eventually leading on to a significant glomerular damage as well as the tubular damage in the background of ongoing inflammation, which leads to eventually to the glomerulosclerosis as well as the tubular interstitial fibrosis, which lead on to CKD. Let's have an example at this. He is a Mr. A who is 60 years age, diabetes of around 6 years, hypertension of around 4 years, creatinine of around 1.2 milligram per deciliter, and his GFR comes out to be 67 mils. And his urine protein is around 1+, urine ACR is around 400 milligrams. He is already placed on lifestyle interventions by his physician. But what is the next step? We are concerned about his creatinine, we are concerned about his GFR, we are concerned about his ACR. So we need to go on for the next step. What is our next step? Is it that we need to give him SGLT2 inhibitors? Is it that we need to give him metformin? Is it that we need to give him ACE inhibitors, ARBs? Or is it all of the above? I understand, yeah, I think Krishna Patil is answering, it's all of the above. So it's all of the above that we need to place the patient on, because there are particular guidelines which have come up with respect to the treatment of diabetes and CKD, wherein the first line of drugs remain the above three, that is the metformin, RASIs, and SGLT2s. So moving on, So this is what is a classical picture which you're supposed to know when you're managing a diabetes with CKD. This comes in our Bible, that is a KDIGO, which says that this is in fact a recent publication in 2022, wherein it's been said that the first step is the lifestyle interventions, which includes the healthy diet, physical activity of around 150 minutes per week, smoking cessation, weight management. The first line of drugs, mind you, ladies and gentlemen, it is SGLT2 inhibitors, metformin, RASIs, along with the statin, and of course followed by this, the green is for the diabetes and the blue is for all the patients. The green, it says that if you're done with your SGLT2s, if you're done with your metformin, if you're done with your RASIs, if the patient's continuing to have albuminuria, mind you, it's not proteinuria, it's albuminuria, please go on and put the patient on non-steroidal mineralocorticoid antagonists, that's MRAs, that's a Findinone. If patient continues to have ACR of more than 30 milligrams per gram, or if the patient needs a further control in the glycemic targets, going for the GLP-1 RAs. So this is how is the algorithm that's been mentioned as far as the management of the diabetes with the CKD is concerned. This in fact is a golden standard table for us as far as the management is concerned. So now let's look at this. First line of drugs for management for CKD diabetes include all except, in fact, I've already shown this in my earlier figure. So the answer is non-steroidal MRAs, because that's not the first line, that's the second line. Here you can see, if you look at this axis again, which is a easily understandable pyramidal approach, where you can see that the first line is always the lifestyle management, followed by the drugs which are easily available. Second line of drug is a non-steroidal MRAs, which is nothing but the Findinone, which has come to India and which many people are using, which they feel, the practicing clinicians feel that there are huge benefits of using Findinone in day-to-day practice. So after 6 months review, this Mr. A comes to us with a creatinine of around 1.3 with a slight decline in the GFR, with urine protein continuing to be 1+, and the urine albumin creatinine ratio appears to be, so not ratio, it is 400 milligrams on lifestyle interventions plus the above said drugs. So serum electrolytes, when they are checked, it's about 134 and 4.9 potassium. So as I said in my earlier slides, we will add a non-steroidal MRAs. This answer is very well known to us. So this is what I have discussed in my earlier slides. So why am I speaking about Findinone so much? What we need to know about Findinone? What is exactly it is doing? So it basically is relevant to the aldosterone mechanism. Aldosterone, please understand, that's a key factor in promoting inflammation and fibrosis, which causes cardiorenal failure. Treatment with ACE inhibitors or RASIs does not prevent the overactivation of MRA, that is a mineralocorticoid receptor. Hence, we need to act on the mineralocorticoid receptors using the appropriate drugs, whether it's a steroidal or non-steroidal. You have to understand that there are certain side effects with steroidal MRAs, so we have come up with the non-steroidal MRAs, which are relatively safe and relatively have many benefits as far as the cardiac protection or renal protection is concerned. So how does it act? This is how, in the background of hyperglycemia and high salt levels and oxidative stress, there is an MR overactivation. You can always see that the Findinone is going to block this MR activation in the background of this oxidative stress, hyperglycemia, and high salt levels. So the tissue effects are like inflammation, fibrosis, oxidative stress, and hypertrophy. On the contrary, when you look at the clinical effects, it's supposed to be reduction in albuminuria, improvement or stabilization of GFR, hypertension control, and of course, a positive outcome on the kidney. So this is a table which is little cumbersome. I don't want to speak about it. So if you look at this, which has been published by the International Society of Nephrology as well as KDIGO, the 4-pillar approach for diabetic nephropathy. The first pillar is RAS blockers. You all know that. The second pillar is SGLT2 inhibitors. The third pillar here comes to our friend, that is the Findinone, and the fourth pillar is GLP-1 RA. So this is how we are supposed to give a sequential treatment for a diabetes who is anticipated to have a CKD, which he is going to have anyways. So pillar 1, I repeat, is RASIs, pillar 2 is SGLT2s, pillar 3 is Findinone, and pillar 4 is GLP-1 RAs. So what am I going to benefit after adding the Findinones? Findinones are going to reduce the risk of the clinical benefit, that is the stroke, and then heart failures, the death from the CV causes, of course the CKD progression, as well as death from the renal causes. Of course, we have to understand there's always pros and cons of using the drugs. The side effect that has been mentioned, though it's not life-threatening secondary to Findinone, is hyperkalemia. But mind you, life-threatening hyperkalemias are not common with Findinone. So let's look at the clinical trials which have come to an understanding at this point what I'm speaking today. So there are a good number of clinical trials which are RCTs, which is like Fidelio DKD, Figaro DKD. So what is this Fidelio and Figaro? Let's have a look at it in a minute. This is the Fidelio DKD which was done. Does Findinon improve outcomes in CKD with type 2 diabetes? The conclusion of this is, in patients with CKD and type 2 diabetes, treatment with Findinon results in lower risk of CKD progression as well as cardiac events than the placebo. So this is the Fidelio DKD that was done. So these are the sub-analysis of the Fidelio. When you look at the Figaro DKD, does Findinon improve cardiovascular outcomes in type 2 diabetes and CKD patients? The conclusion is, among the patients with type 2 diabetes and stage 2 to 4 CKDs, I hope you all understand that the CKD is staged based on the GFR, which normally is supposed to be 90. Anything below 90 with proteinuria, we are going to stage the GFR. So depending on the GFR, the patient may be at stage 2, stage 3, stage 4, stage 5, or probably stage 1. But here in this Figaro DKD, we are going to speak about stage 2 to 4 CKDs, wherein it's been mentioned that among the patients with stage 2 to 4 with moderately elevated albuminuria, which you commonly colloquially call as microalbuminuria, or stage 1 to 2 CKD with severely elevated albuminuria, Findinon is going to show immense benefit. So Findinon has been shown to show effective outcomes in the cardiac as well as the renal outcomes in variable stages of CKDs, just not the final stages or early stages, in variable stages of CKD. This is a conglomerative analysis of Fidelio and Figaro, which is called as Fidelity. So what does Fidelity say? Fidelity says that Findinon improves the kidney outcomes, including reduction of the end-stage failure, and is well tolerated in CKD patients and type 2 diabetes. So what I mean to say is that Fidelity is a conglomerative or a cumulative analysis of Fidelio and Figaro, wherein a pre-specified individual patient data pool analysis was done and said undoubtedly that the Findinon is going to have a potential benefit in reduction of the cardiovascular outcomes and in reduction of progression to end-stage renal disease. So what does it say? Fidelity HF analysis demonstrates the consistent benefits of Findinon on heart failure-related outcomes across CKD stages in patients with type 2 diabetes, regardless of eGFR or USAR at the baseline. So you do not worry about what's the GFR, but what is the albumin-creatinine ratio. You start the patient in Findinon. But mind you, at this point of time, the cutoff GFR for start of Findinon is about 25 mL per minute. Anything lesser than that, please do not start, because the side effects are going to be more. But anything above that, you are at liberty to start a patient of diabetes and CKD on Findinon. Recent findings from Fidelity HF support the use of Findinon and highlight the importance of routine screening for renal function in primary care to identify kidney decline early in patients of diabetes. So these diabetic patients, in fact, in the level of the primary care physician, instead of referring the patient to a nephrologist or probably a broad specialty medicine, the primary care physician should be able to take care and evaluate the presence of renal abnormalities, whether it is a GFR decline or whether there is a presence of albuminuria in the urine, and start the patient promptly on Findinon, so that the long-term effects and the advantages of Findinon are well utilized by the patient. So this Mr. A, whom I was speaking about, he comes after 6-month review, and his investigations are as follows. His UACR has reduced from 400 to 160 milligram. His GFR is stable at around 60 mL per minute. Are we happy? Yes, no, maybe. Probably we should say that we are happy because we have seen a reduction in albumin-creatinine ratio. There is a significant drop in albuminuria. If you look at this Fidelio analysis, what it says that UACR reduces by about 39%. In this patient, it has come down by 40%. So Findinon has reduced the albuminuria, hence it is supposed to be useful. And if you look at the GFR maintenance, this is the Findinon effect that has been shown across various stages of the GFR. The C group, which our patient belongs to, wherein the GFR is around 60 mL, the preservation of GFR compared to placebo is much better. So we need to understand that Findinon preserves the GFR, Findinon maintains the GFR, hence it is better that we start Findinon at the early stages of diabetes with CKD. So UACR 160, GFR 60 mL, so we are happy. So the patient is on right treatment. 1 year after this, he comes for a review. Now his creatinine is around 1.2 milligram per deciliter. His albumin creatinine ratio is about, albuminuria is about 180 milligram. But the serum electrolytes, if you look at it, it's slightly elevated. The potassium has come up to 5.9. What am I supposed to do? Should I continue on Findenone? Should I stop Findenone? Or should I decrease the dose of Findenone? What am I supposed to do? Now let's look at this. So the basic thing that we are concerned about the side effects of Findenone is potassium. You sequentially follow the potassium, like the way you follow the creatinine potassium when you start a patient in RASIs. In Findenone, focus on potassium. If the potassium is normal, do not worry. But if the potassium is elevated, we do have certain strategies as to coming down on the dose of the Findenone and then restarting it. Let's have a look at it. If it's less than 4.8 millimoles and the baseline GFR is more than 60 mils, continue Findenone 20 mg per day. If the potassium is less than 4.8, baseline GFR 25 to 59, reduction in eGFR after 1 month is less than 30%, can consider increasing dose of Findenone from 10 to 20. Otherwise, Findenone 10 mg daily. But if there is a slight increase in potassium, maintain at 10 milligram. But if the potassium increases to more than 5.5, probably you need to withhold the Findenone, consider other therapies which can control the potassium, including the diet. And once the potassium levels are repeated of 72 hours, it comes to normal, probably you can restart the Findenone, because your benefits and advantages of Findenone are beyond anything. So what are the 5 grade 5s or high 5s of Findenone? Let's have a look at it. One is type 2 diabetes with CKD. You can start the patient on Findenone. Potassium less than 5, start on Findenone. eGFR more than 25 ml, start on Findenone. Urine albumin creatinine ratio more than 30 milligram, start the patient on Findenone. 5 points for exclusion. If a patient is on steroidal MRAs, such as spironolactone or eplerenone, you're concerned about your hyperkalemia, so do not start. And if the patient is pregnant or lactating or severely hepatic impairment, adrenal insufficiency, please do not start on Findenone. Regardless of the glucophenotype and the cardiac status, you can always continue the patient on Findenone. But what are the things that you're supposed to monitor when a patient is in Findenone? Serum potassium, urine albumin creatinine ratio, eGFR, blood pressure, and serum creatinine. The outcomes are also supposed to be invented. Reduced risk of ESRD by 1/5%, heart failure by more than 1/5, reduced urine albumin by 32%, cardiovascular mortality by 12%, and low clinical impact of hyperkalemia with incident rate of permanent discontinuation is about 1.7%. So key takeaways of 5 5s of Findenone are: initiate if potassium is less than 5, withhold if it's more than 5.5, GFR if it's more than 25, Findenone reduce the risk of ESRD by 1/5, reduce the risk of heart failure by more than 1/5. Now, what are the guidelines? A quick look at the guidelines. This is a KDIGO, which says that the level of recommendation is 2A. 2A stands for we suggest. A is very strong. So we suggest a non-steroidal MRA with a proven kidney cardiovascular benefit for patients with type 2 diabetes and eGFR of more than 25 mL, normal serum potassium concentration and albumin of more than 30 milligram per gram. What do the other guidelines say? Other guidelines also say that there's a consensus. There is various societies which have said that there is a key role for RASIs, SGLT2s, and non-steroidal MRAs to be initiated. This is again the same thing which is being reiterated. George Bakris is the one who has done immense studies as far as the Findenone is concerned. He said, we have a general agreement between diabetologists and nephrologists on use of Kerendia. Kerendia is the brand name of the Findenone as a part of treatment plan for patients with CKD associated with type 2 diabetes. This is a KDIGO which has recommended the sequential treatment, which is RASIs, followed by SGLT2s, followed by non-steroidal MRAs, and followed by GLP-1 RAs. Coming to the practical aspects, let's have a quick look at it. You people may be confused what is UACR, but UACR, instead of using the proteinuria, which is done on dipstick, it's better that we use UACR. But then practically, maybe if it's difficult for us, we can still use a dipstick proteinuria. So when do I use Findenone? How does, if the presence of certain conditions, are they going to affect my Findenone use? What if my patient is with high HB1AC? What if he has long duration diabetes? What if he is elderly? What if he is on insulin? What if he is on SGLT2s? Blah, 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 blue, blue, blue. Nevertheless, do not worry about all these things. Add Findenone if your albumin is on the higher side, if your GFR permits you to do so. So for practical use, this is how we are supposed to look into. Initiate when UACR is more than 30 milligram, potassium less than 5, eGFR more than 25. Intensify after 1 month from 10 to 20. Control or monitor the potassium levels. Modify the drug if the potassium is increasing. And increase the dose of the Finerenone from 10 to 20 if you're allowed to do so. So this is the algorithm wherein it is said the stepwise approach of a diabetic kidney disease with respect to RASes, SGLT2s, and the Finerenone in relevance to the potassium.
The time is up.
Yeah,
Manjush.
ending up, yeah. So the last question is, can I add Finerenone with the SGLT2s? The answer is yes. There are a lot of trials which are coming up wherein Finerenone is being combined with the SGLT2s and being given. So we are at liberty to combine the Finerenone along with SGLT2s. So finally ending my talk saying that the patients of diabetes and CKD doesn't belong to diabetologists or nephrologists or primary care physician, but belongs to multidisciplinary care. It's a team approach, as has been said by Katie Go and International Society of Nephrology. So all of us have to come together to treat a patient of diabetes and CKD and start the patient on appropriate treatment so that the cardiovascular benefits and the renal benefits are to a maximum in this particular group. So all birds find shelter during a rain, but the eagle is the one which avoids the rain by flying above the clouds. So let's all be the eagles and try to minimize any complications that the diabetic patients are going to face by using the amazing drug that is a Finerenone. Thank you so much for your attention.
Yeah, thank you, Manjusha. For definitely, Finerenone is added to the armamentarium for treating diabetic kidney disease and especially the cardiac metabolic kidney disease syndrome, the cardiac kidney metabolic syndrome. Just wanted to ask your personal experience about Finerenone when you are using to the patients.
Yeah, madam, we have started, but the side effect that has been mentioned, see, it is too short a time for me to say whether the long-term benefit is there or not. And then when we are starting the drug, we are looking at the proteinuria rather than albuminuria, because albuminuria is not the one which is easily available in all the labs. We're still depending on proteinuria. That's a major crux of it. But if the proteinuria is continuing, we are adding after 3 months of SGLT2s, we have just started adding. The long-term benefits I am yet to experience. But then the side effects that have been mentioned as life-threatening hyperkalemia and all we are not seeing. So that way I still feel, though it is too early to say, yet it is definitely has a very good role in management.
Have you had any chance of adding any K-bind sachets?
No, madam, that's what I'm saying. That much amount of hyperkalemia is never seen in our group, despite the patients being in RASes as well as, Kerendia.
Sure.
Yeah.
Thank you so much.
Thank you. Thank you so much.
Because of shortage of time, we'll not take any audience questions. Second, the next is treat to target or versus treat the organ. It is a panel discussion between Dr. Ratan Jha and Dr. Ashutosh Kumar. I would introduce Dr. Ratan Jha is a senior consultant nephrologist and a transplant physician in Care Hospital, Banjara Hills. He's a teacher, is an invited national faculty for various medical forums with different research papers, 75 research papers in peer-reviewed journals, 200 presentations. There are multiple chapters in books. Along with him, or versus him, is Dr. Ashutosh Kumar. He's a cardiologist, senior consultant cardiologist, electrophysiologist. Yeah, thank you. Go ahead, sir.
Good afternoon, everyone. At the outset, I will thank the organizers for giving me an opportunity to talk on a very important topic. I'm a dual panelist because I'm going to talk about treat to target, what's a treat the organ, because the second panelist has not come. So my time will be slightly more than 15 minutes. So I'm going to cover this talk as how to treat to target or how to treat the organ, whether choosing one kind of approach is correct or not. So when we talk about treat to target versus the treat the organ, the targets are very clear-cut in clinical practice for a nephrologist. The ABCD target, to remember the points clearly in a patient of chronic kidney disease with diabetes. A means trying to look at the A1C or time in range, B for blood pressure, C for cholesterol, D for diet, E for exercise, and there are many other things that has to be added on. So this is just an algorithm to remember that what we mean by target. And this target has to be always achieved, because without reaching the target, we may not be able to protect the organ. But both of them are not exclusive. They are complementary to each other. And when you're talking about organ protection, we have to choose an approach and a target which is protecting the heart, protecting the kidney, liver, and other areas like in reducing adiposity or weight. There's a new term now which has been devised in which has been recommended in 2023 by American Heart Association. That is a CKM syndrome. That is a cardiovascular kidney metabolic syndrome, because this is a kind of conglomeration of risk factors which are occurring together, and it has to be appropriately targeted in a patient who has all these kind of combinations to get to the goal. So both the approach that treating to target versus treating the organ are complementary, and we need to have a right combination, a right mix to get the best result. So as a nephrologist, when we are earlier treating a patient of diabetes with kidney disease, we were thinking kidney as a victim of diabetes. But now the things have changed. There has an evolution of kidney from only being looked as a victim of diabetes to a target organ in diabetes management. Because now we are using the kidney to target the diabetes. And when we use a drug like SGLT2 inhibitors, it is commonly said that this drug ultimately affects the pump, pipe, and filter. The three important areas which ultimately leads to a kind of poor outcome in many patients who are having a combination of these characteristics. That is, it reduces the heart failure by looking at the pump. It is trying to protect the kidneys or filter by reducing the nephropathy, and ultimately by reducing the atherosclerosis in the pipes, it is reducing the kind of atherosclerotic cardiovascular disease and death. So this is a wonder drug which has to be appropriately utilized not only for managing diabetes but also for managing a chronic kidney disease patient to target these three important events. So this is one of the slides that just to include in this presentation is that when we're talking about managing such patients, the cardiovascular kidney metabolic syndrome has to be appropriately understood. This cardiovascular kidney metabolic syndrome is also staged. As we talk about CKD staging, this the CKM stage is also staged into stage 0 to 4, and it is only a kind of concept to decide at what stage of disease, what kind of approaches will be appropriate to get to the goals of organ protection as well as the target attainment. So, CARE-ME approach, a kind of abbreviation of the cardiac, renal, and metabolic approach, aims to manage a patient with chronic metabolic disorder by addressing the shared risk factors between these distinct but interrelated diseases. And two of the diseases which are mostly focused in the day-to-day management is protecting the heart, that is coronary heart disease, and protecting the kidneys. Though we cannot ignore the chronic liver disease, which were earlier having a kind of affection because of metabolic syndrome as NAFLD, but a new name has been put instead of NAFLD. We are talking about MAFLD, that is a kind of metabolic disorder associated with steatohepatitis with steatohepatitis. So the nomenclatures have changed, but the disease is same, the risk factors are same. So when we talk about organ, we're talking about the organ of heart and organ of kidney, because these are two major organs which ultimately leads to increased mortality. So we will see how we try to protect the heart by using the appropriate drug, why it is important that we need to save the heart. Or we know that patients of diabetes with or without kidney disease are very high risk of heart failure. And heart failure for a clinician is heart failure with either reduced ejection fraction, heart failure with mid-range ejection fraction, or a heart failure with preserved ejection fraction. In a nephrological specialty, in a patient who is not having diabetes, the heart failure with preserved ejection fraction is the commonest presentation. But in a patient who has diabetes with kidney disease, both types of heart failures are seen. More commonly, the preserved ejection fraction in the beginning, and subsequently it evolves to a mid-range and reduced ejection fraction. So a patient who is having a kind of heart failure goes through different stages of heart failure. That's from stage A, when he or she has only a kind of risk factor, to a structural heart disease, stage B, or stage C when the person develops signs and symptoms, and stage D is a disease which is refractory heart failure. And with the progressive increase in the heart failure, the worsening, the patient keeps on having repeated hospitalization with either acute coronary syndrome or associated with a kind of hospitalization with heart failure with acute coronary syndrome. So this is a disease which is a progressive disease, and it has to be targeted appropriately with the drugs which are now available. We know that patients who are having any form of heart failure are at increased risk of heart failure with admission. They have all-cause mortality is also increased in any categories of heart failure, whether it is reduced ejection fraction, mid-range ejection fraction, or a preserved ejection fraction. So heart failure by itself is a risk factor of death, and we need to have appropriate drug therapy and approach to have a better result. So this is a slide just to reinforce the point that as a patient who develops heart failure over the years, like from the first admission to the 5 years of follow-up, they have more and more chances of heart failure hospitalization with an increased risk of death. And hence, this is an area which has to be targeted with the drugs. This is called goal-directed medical therapy for taking care of such patients. So the goals of pharmacotherapy for achieving this, for reducing the incidence, prevalence, hospitalization, heart failure is that we try to reduce the mortality by using the right drug combination. We have to prevent the recurrent hospitalization due to worsening of heart failure and improve the clinical status of the patient by adjusting the drug dosing as per the comorbidities to improve the functional capacity and quality of life. So these are the goals of pharmacotherapy, and these goals will be met. How do we meet the goals is going to be spoken in the subsequent slide. What heart failure guidelines are recommending in this context is shown in this slide, that the 4 pillars of therapy, that when we talk about heart failure with any form of ejection fraction, the reduced ejection fraction, the pillars are clearly defined. First is the RAS blocker, ACE-ARB, beta blockers. The second pillar, third is the mineralocorticoid receptor antagonist, spironolactone and not finerenone for reduced ejection fraction, and dapagliflozin or empagliflozin, the fourth pillar, with loop diuretics. And beside these pillars, as per the need, based on the QRS prolongation, we may go for a kind of cardiac resynchronization therapy or a kind of implantable cardiovascular device in case it is required. And these are the grade 1, class 1 or class 2 recommendation. But 4 recommendation that is shown in the top of the slide is the part of every patient therapy. But when you talk about heart failure, preserved ejection fraction, the guidelines are not clear. But one thing is clear is that SGLT2 inhibitor has to be utilized to treat such patients, and along with that, loop diuretics, mineralocorticoid receptor antagonists, ARNI and ARB, which are the pillars of therapy for reduced ejection fraction, has to be utilized appropriately as to improve the symptomatic symptoms of the such patients. So, if we look at the European Society of Cardiology update, the patient with heart failure with mid-range ejection fraction or a patient with heart failure with preserved ejection fraction, what is clear is that class 1 recommendation for mid-range ejection fraction is diuretics, empagliflozin, but ACE inhibitor, MRA and beta blockers are class 2 recommendation. For preserved ejection fraction, the only class 1 recommendation is using dapagliflozin or empagliflozin with diuretics. Other things will be required because most of the things are associated, and you have to take care of cardiovascular comorbidities with appropriate drugs, and same drugs are practically used. So the role of SGLT2 inhibitor for such patients in the medical therapy is going to be discussed. What is clearly shown in this slide, that when we try to combine that 4 pillars, there is a kind of clear-cut 64% risk reduction of mortality, that if you are using ARNI, beta blocker, MRA, SGLT2 inhibitors in patients who are having heart failure with reduced ejection fraction. And any other combination, when we give, though there may be a benefit, but the benefit doesn't match this quadruple combination, and this has to be remembered that we need to use all the 4 pillars to get the best result in patients with heart failure with reduced ejection fraction. So what was shown in the DAPA-HF trial, that is dapagliflozin used in heart failure, in patients who are having heart failure with reduced ejection fraction, by 1 month time we got a clear-cut kind of separation of the curve, that the benefits were seen as early as 1 month, and it had a kind of clear-cut impact on the cardiovascular death, worsening heart failure, cardiovascular death, and all-cause mortality. That is, the benefit was seen and it was sustained. So what is new in the update in the management of heart failure with mid-range ejection fraction where the ejection fraction is above 40%? This was addressed in the DELIVER trial where the similar kind of patients were utilized with the same kind of clinical characteristics, but the ejection fraction was above 40%. And one arm received dapagliflozin and other arm received placebo. And what was seen is that the primary composite outcome of such patients, so far cardiovascular death, heart failure, hospitalization, or urgent heart failure with visit was concerned, was seen much early. That is, even before 2 weeks, the separation was seen, and that the risk reduction was significant statistically. So there was a consistent treatment benefit across all the pre-specified groups in this DELIVER trial, and that is to say that even in patients who are having heart failure with preserved ejection fraction, we need to use this drug. So the evidence for dapagliflozin across the full spectrum of EF has been reanalyzed in the DAPA-HF and DELIVER pooled analysis, that when they combined both the DAPA-HF and DELIVER trial, where ejection fraction was below 40% and above 40%, what was seen that this pooled analysis showed a similar kind of benefit, that it was a benefit across all the kind of the outcomes, that cardiovascular death, all-cause death, total heart failure hospitalization, first heart failure hospitalization, MACE, we are favorably affected. That is to say that this is the first group of drugs which are found to be useful in patients who are having heart failure with preserved ejection fraction. Before that, we were not having any standard drugs to be given for reducing the risk, but those same drugs were given for comorbidities. So when we look at the comparative benefits of dapagliflozin versus empagliflozin, which is another competitive drug which is in the market, what is the benefit of dapa versus empa is going to address in the next slide. So what was seen in the EMPEROR reduced, which was a trial where ejection fraction was less than 40%, or EMPEROR preserved ejection fraction more than 40%, where the empagliflozin was used. The benefits, at least for so far cardiovascular death was concerned, was not seen with empagliflozin. But the trial was a bit different from what was the trial in this DELIVER trial combined with the DAPA-HF trial. So we cannot compare it totally head to head. Dapagliflozin was the first disease-modifying therapy, therefore, which was found to be effective across the left ventricular ejection fraction spectrum, from low to mid-range to high ejection fraction. So if we compare the two molecules which are there in the market, dapagliflozin versus empagliflozin, what is shown in this slide is that dapagliflozin has a kind of risk reduction which is there quite significant compared to the empagliflozin. So at various kind of statistical comparisons have found that dapagliflozin probably is better than empagliflozin, but this kind of this comparison may not be the right way to compare because the patients were a bit different. So in summary, dapagliflozin, which is an innovative molecule in the name of Forxiga, which is available, helps in saving patients' lives with robust clinical trial data and guideline recommendation. And this is based on the trials that we talked about, the DAPA-HF, DELIVER trial, and a pooled analysis. And it has been seen to benefit even in the real-world situation. So now coming to the second organ protection after the heart is the CKD. How we try to use this drug in the CKD as far as the management of CKD is concerned. CKD has emerged as a major global public health problem, and its prevalence is increasing throughout the world. And because of this increasing prevalence, the cost of therapy is also increasing. And it has been reported that the rates of CKD mortality has increased, and so also the kidney replacement therapy with the cost of taking care of such patients is going to increase throughout the world, and if you are not able to contain the disease progression. So what is the guideline which is giving a recommendation in this context to take care of this emerging threat of CKD worsening? So this is a slide which has already been presented by my previous speaker, that the algorithms are very clear, that in a patient who is having chronic kidney disease, after the lifestyle, SGLT2 inhibitor, it will be the first line additional therapy with or without metformin as per the diabetic status, and subsequently we can add other drugs. So the role of dapagliflozin for CKD is going to be discussed in next few slides. The DAPA-CKD trial was a very important landmark trial which included various kinds of patients, diabetic versus and non-diabetics, with a GFR range between 25 to 75 and a proteinuria range between 200 to 5,000. And one arm was getting dapagliflozin and other was on placebo with a 2.4 years of follow-up, a large number of patients of 304. What was found in this trial was that it was the first CKD trial which demonstrated clearly the cardiorenal benefits and the mortality benefit. That is, the primary composite outcome of kidney disease, heart failure, heart disease, as well as mortality was reduced by 39%. All-cause mortality was also reduced. And the composite cardiovascular death, which was secondary endpoint, was also reduced. So it was a win-win kind of thing from every angle for patients who were getting a treatment with dapagliflozin in the context of CKD. So when the subgroup analysis was done, what was found that patients who were having diabetes versus non-diabetes, they were equally benefited. That is, whether a person is diabetic or non-diabetic, kidney disease of any type was benefited with the use of dapagliflozin in this DAPA-CKD trial. And when secondary outcome was looked at, that mortality of diabetic versus non-diabetic, it was found no way different. Both the group had a similar benefit. It was also noted in this trial of DAPA-CKD that patients who have received a drug, dapagliflozin, had a 33% risk reduction of diabetes. So it can be considered as a drug, a primary prevention drug in a patient who are getting dapagliflozin for some other reason to prevent diabetes. 33% kind of risk reduction of diabetes in patients who received this drug. So ultimately, what is the message from this data of the DAPA-CKD trial is that when we are looking at the primary composite outcome, there was a kind of good risk reduction. It benefited diabetic patients with nephropathy, ischemic hypertensive disease, glomerulonephritis, and other unknown cause. So all-cause mortality was reduced in all these categories, and all patients who were included in this trial had a kind of cardiovascular benefit. So patients benefited irrespective of the etiology and proteinuria. The best benefit was seen in a proteinuric patient. So dapagliflozin, when it was analyzed based on this primary kidney disease, IgA nephropathy is considered to be a commonest glomerular disease throughout the world. This is the commonest form of chronic glomerulonephritis. It was also included in this trial, and FSGS also is an important primary glomerular disease were included, and they also benefited in this trial. That is, there was a kind of good risk reduction, 71% risk reduction in IgA nephropathy, and FSGS 38% risk reduction. And hence, this has become a part of therapy in all patients with glomerular disease who are not totally got remitted with the primary care of immunosuppressive drug therapy. So this is an add-on therapy even for IgA nephropathy and FSGS. So the cardiorenal benefits was seen in patients who were started early in stage 2 to 3, 42% risk reduction, and stage 4, that is late stage of disease, when they were given even that stage, it benefited the patient. So dapagliflozin in this trial was found to be well tolerated. There was hardly any kind of difference so far side effects were concerned from the placebo. So the last few slides, are all SGLT2 inhibitors same when we are trying to take care of the cardiac, renal, and metabolic risks? So this is a slide just to highlight the point that in this DAPA-CKD trial and DAPA-HF trial, when they compared head-on, though they were a different kind of population, it was found that Farxiga scored higher in the statistical kind of benefits. So far, glycemic control was concerned, all-cause mortality was concerned, heart failure hospitalization was concerned, and death was concerned compared to empagliflozin. But this comparison may not be a valid comparison because patient population was different. Coming to the last point, are originals or the drug which are research molecules same as generics? It has been reported that it takes a long time for kind of originals or innovative molecule to go before it becomes patented. And when you talk about original Farxiga versus the generics, what is shown in the last column that hemoglobin A1C is better reduced with the innovator compared to generics, and the noxuria was reported to be lesser in patients who were getting original, probably saying that the diabetic was better controlled. It has been reported in our publication that innovators are like itraconazole was getting a better result compared to generics from PGI Chandigarh. Same thing was reported about cholecalciferol as well as the Farxiga versus DAPA. That is to say that this innovator and as well as generics may not be same. So last 2-3 slides, the multifactorial management. When you talk about managing a complicated disease like chronic kidney disease or diabetes, we need to go at multiple steps. That if you are controlling blood pressure with not the best drugs, what benefit you see is not as same as when you use RAS blocker. When you use SGLT2 inhibitor, the curve changes, and when you use finerenone, the curve changes further. So it has been reported that one can get a 16 years of extra life when SGLT2 inhibitor is added to a DAS blocker, and 6 years of extra life so for dialysis delay is concerned if finerenone is given. And this is a mathematical model which is recently published in 2023 IMPACT kidney trial, that even if you are using a patient with a GFR at the 20 ml, we can delay the need for dialysis by 2 years. And if you are using with the GFR 85, almost 25 to 30 years of extra life without dialysis will be required. So to conclude, there's a need to intervene early with the last slides. It's stuck. So to conclude, it is important that we need to start the therapy early. We need to use dapagliflozin appropriately in the right dose, in right patient. Just waiting for my last slides because that is the most important message that you wanted to convey. CKD, go to the previous slide, next slide. So the message is that when we are using CKD continues to be a major public health problem, and in India the incidence of CKD reported prevalence is reported to be not 10%, it is close to 17% in the recent reports. Kidney replacement therapy is also increased, which is a global burden, including the burden in India. The risk of mortality and cardiovascular deaths are elevated regardless of CKD etiology. Dapagliflozin is the first therapy over 20 years to reduce the risk of CKD progression, cardiovascular event, and mortality. Originals are originals. That is to be always remembered, that it cannot be a copy which can be replacing the things. But in a situation where a person is forced to use a drug because of financial status, one can always go for a kind of the copycats, etc. Last slide. Thank you. So I had to finish on time because I was trying to cover for both the speakers, and I tried to do my best to finish in 20 minutes. Thank you.
Thank you, Dr. Jha. Treat to target versus treat the organ, wonderfully presented. We'll have questions at the end of this session.
Yes.
The next speaker I would like to invite, Dr. Bizu Govind, interventional cardiologist from Sri Sri Holistic Hospital. The topic he's going to talk will be holistic cardiorenal metabolic care with SGLT2 inhibitors, DPP4 inhibitors combination in type 2 diabetes mellitus. Dr. Bizu Govind is interventional cardiologist. He is well known for his coronary structural heart disease interventions for the last 2 decades. He received his fellowship from American College of Cardiology, USA in 2015. He took the fellowship in the Society of Cardiovascular and Angiography and Interventions in USA in 2013. He is professor of cardiology in the Department of Medical Colleges. He is co-convener of the AP chapter of Cardiological Society of India, held in July 2009. He is faculty in many international and national conferences. He has many international publications. He has vast experience of research work and paper presentations at international and national conferences. The floor is yours.
Thank you, sir, for the kind words of introduction. So thanks to the organizers and the chairpersons and friends and dear colleagues. My job is made a little bit difficult because the previous speaker has literally spoken a lot on positives of dapagliflozin, which I don't disagree with, but the negatives of empagliflozin, which I will have to, it's not a direct head-to-head fight, and we all know that these drugs have never been compared together in a head-to-head trial. So all of them are conjectures, so let the best drug win and let the patient benefit ultimately from whatever we have in the market. My job here is to talk on cardiorenal metabolic care. I'm sure some of you are better than me in some aspects of this talk, but I'll try to make it brief and stick to my time. So let's skip the definition. I'm sure by the end of the day you had multiple talks on the same on related topics. So let's talk about the disease burden first. We know that CKD is a big problem in the population, and the undiagnosed numbers of CKD are much more than the diagnosed figures. And most of the CKD patients ultimately end up dying due to heart disease, in many cases heart failure, and in some cases due to obstructive atherosclerotic disease. Things have changed over time from what was a glucocentric approach to a risk factor approach or an organ-specific approach in the management of diabetes. So from HbA1c control, which is important, nevertheless, we have moved to something beyond HbA1c, that is controlling the multiple various organs and the safety. So the end goal and the early management now would be early intervention. Could we imagine glucose-lowering drugs to be used for non-glycemic indications? I think maybe 6-7 years, maybe 7-8 years earlier, we wouldn't even have thought about that. Now we use them for weight management, we use them for heart failure reductions without diabetes, or renal failure protection, CKD worsening, prevention of worsening of CKD in non-diabetic as well. So things have changed a lot in the last 6-7 years, and that has been good for all of us and good for our patients as well. I'll base my talk for the next 10 minutes on a hypothetical case of a 50-year-old lady who was diagnosed as diabetic 8 years ago. She is also hypertensive and she has dyslipidemia, and she was hospitalized twice. That's important. She was hospitalized twice for heart failure in the last year. She has a concern of missing drugs. So she's a 50-year-old bank executive, so she has a busy lifestyle, and she has a problem with her drugs as well. When she underwent her that's the current therapy she is on. As we can see, she is on sitagliptin and metformin for her diabetes. She is on low doses of 50 mg per day there. That's actually a chicken feed dose of ARNI for heart failure. Probably her blood pressures were borderline, so we assume that's the reason why she was on such low doses. She's on a beta blocker, she's on a statin, and she's on amlodipine as well. I would probably have decreased amlodipine and increase ARNI perhaps in this patient. But more important things to discuss here are her blood parameters and the urine parameters, which show that sugars are not under control. As we can see, the HbA1c is around 7.8. LDL cholesterol is slightly above what should be our range target, which should be definitely below 100. She has LVH. There's no surprise because she has been hypertensive for a long time. Her rejection fraction is 50%, so it's subnormal, but it's not really low. Her BMI is slightly more, but it's all right. It's not very high. Creatinine is normal. eGFR is reaching at 70 mils per minute. UACR, we had a lengthy discussion, 2 talks on UACR. So by the time we know that it is elevated and it's not looking good at all. She has some pus cells in the urine. We know that genital infections are an issue with SGLT2 inhibitors, so the importance of looking at the pus cells in the urine. So the concerns for her are she has a below normal ejection fraction. We call it heart failure with preserved ejection fraction. She has hyperglycemia, which needs better control. She has albuminuria. Adherence is a concern, so pill burden is something we should be carefully looking at. I'm not really bothered about pus cells because she is asymptomatic and she doesn't have any active UTI features. So probably that's not a major cause of concern in this particular case. So we have multiple options we have for this patient, like addition of a sulfonylurea. With the current available drugs, I don't think many of us would prefer that as an additive therapy for her. SGLT2 inhibitors, we do not know how complementary it works. Yes, it is an option. GLP-1 receptor agonist, she is not obese too much, and the tolerability concern because of gastric issues could be a cause of concern, of course, considering that money is not an issue for her. Insulin, of course, we don't know, not many of our patients prefers insulin. We have a combination of SGLT2 inhibitors with DPP4 inhibitors, FDC, the fixed dose combinations, which I'm going to talk for the next 5 minutes or so. How bad is the CVD prevalence in diabetes? This study, the CAPTURE registry, actually does not have Indian patients, except for a couple of outlier countries like Saudi Arabia and Czech Republic. Majority of diabetic patients, about 30% of people, 34% to be in the overall figure, have CVD. So CVD prevalence in diabetics is pretty high. So to summarize the whole slide, 1 in 3 adults with type 2 diabetes have established cardiovascular disease. And worse than that, 50% of them die ultimately from cardiovascular disease. UK PDS, though we know that macrovascular diseases may not decrease much with strict glucose control, we know that heart failure has a direct correlation with HbA1c control. So worsening HbA1c has greater incidence of heart failure. And heart failure is as bad a disease. Even heart failure with preserved ejection fraction is a bad disease to have. Even we had a small study we had 400 patients of heart failure we studied a couple of years ago and published earlier, which showed that each levels of HbA1c, we made it into quintiles of HbA1c, and each higher level of HbA1c, each higher quintile has worsening heart failure prevalence. The ejection fraction is widely used to categorize heart failure, though as a cardiologist, we know that there is much more to the echo report than just ejection fraction, but for simplicity and for usage in day-to-day clinical practice, we have a quick way of differentiating patients based on heart failure, based on ejection fraction, to heart failure with a reduced ejection fraction, mid-range ejection fraction, and heart failure with preserved ejection fraction when it's above 50 but below normal. We have another terminology there which we will skip. So let's skip this slide for need of time. So even Indian expert opinion actually recommends us to use, when the HbA1c criteria are applicable, to initiate SGLT2 inhibitors with proven benefits, so that as far as heart failure benefits are concerned, I'm sure that any of the SGLT2 inhibitors available in the Indian market would be good enough for that. And DPP4 inhibitors with proven cardiovascular safety. Here we actually are dealing with only linagliptin or sitagliptin, which have proven safety. So essentially we end up with any of the 4 SGLT2 inhibitors, the proven ones in Indian market, with lina and sita, which are also available in our country as of now. Combination therapies do better than individual drugs. I'm talking about empagliflozin and linagliptin combination works better than these drugs used individually. And importantly, the early benefits gained at 12 weeks is maintained till the end of the study at 52 weeks. So these drugs work well in tandem, and the results and benefits are sustained throughout the 1-year period of therapy. We'll discuss the 2 drugs together in the next 4 slides. Separately in the next 4 slides. Empagliflozin, I know it's actually nitpicking actually, like the previous speaker actually spoke on how DAPA could be trumping EMPA on some parameters. But for example, if you nitpick a few parameters, like if you are looking at heart failure hospitalizations, any of the 4 gliflozins tick all the right boxes. So also as far as renal outcomes are concerned. Left to my choice, I'd probably use canagliflozin because the credence is the first one to come, and now we don't have the black box warning for amputation risk. So probably canagliflozin as far as renal outcomes are concerned. But with EMPA kidney and the DAPA CKD trials coming out, all of them anyway are good enough there. As far as CV death is concerned, we have empagliflozin, which is the only one which qualifies there. And 3-point MACE, you have CANA and EMPA. Of course, again, as we have always been telling you, we cannot put head-to-head and compare because none of these studies are on the same patient category or same patient pool, or even the inclusion criteria were significantly different in most of them. Now, let us come to the empagliflozin per se. As we can see that the confidence interval, actually even the upper limit of confidence interval crosses the line of unity on day 17 as far as the hospitalization for heart failure events are concerned, and it is maintained till 100 days. And if you include CV death also as the criteria along with HHF, you see that the upper limit of confidence interval crosses unity on day 27. Again, the benefits are maintained till the end of the study. So all of these drugs do good as far as MACE and CV death are concerned, and HHF are concerned. All the 4 drugs do equally good, significantly better than the placebo. But as far as CV death are concerned and MACE events are concerned, probably EMPA, and in this case canagliflozin, and in this case EMPA alone, does better than the placebo compared to the other drugs. So there are some things where EMPA probably does better. As far as the Emperor Preserved trial, in this lady, of course, we know that she has preserved ejection fraction. So if you look at the data from the Emperor Preserved, empagliflozin does better than the placebo. Benefits as far as the primary endpoint is concerned is attained even on day 18. So I do not know when was the last drug which we had, if we ever had one, where the benefits are seen as early as the 3rd week. They are incredible results actually, whichever SGLT2 inhibitors we talk about. So as far as progression of albuminuria is concerned, because our patient has microalbuminuria, and the drug does better compared to the placebo as far as the progression to macroalbuminuria. So our lady, who is our patient, would definitely benefit with empagliflozin in all the parameters, in glycemic control is concerned, risk factors are concerned, and renal safety is concerned. Quick couple of minutes on linagliptin. Linagliptin and sitagliptin both are safe as far as the cardiac endpoints are concerned. I have issue with saxagliptin because it had some increased hospitalization for heart failure. There was a trend to increase hospitalization. In fact, it's a 27% increase. Allogliptin and sitagliptin, sitagliptin was safe. Allogliptin, we don't have it, so we will not talk much about it. Saxa is available in India, and I have an issue with that. Sita and Lina are safe as far as cardiac safety is concerned. As far as reduction in albuminuria is concerned, in the Carmelina, we know that it was better than the placebo for albuminuria reduction as well. So that is on top of ACE, ARB, and metformin. So the ADA standard of care says that on the effect of MACE, CANA and EMPA are acceptable. Heart failure, all the four SGLT2 inhibitors are acceptable. As progression of DKD is concerned, CANA, DAPA, and EMPA, all of them are acceptable. Metformin, as we can see, are neutral as far as heart failure and DKD is concerned, but it still forms, as far as all the trials are concerned, it still forms the first-line therapy. I personally believe it's only a matter of time before one of these SGLT2 inhibitors become the first line of therapy. It still is the first line of therapy in some specific subsets of people. We all know that patients who are ASCVD are GLP-1 receptor analogs or proven SGLT2 and inhibitors as a first line of therapy. If stroke or TA is concerned, we know that GLP-1 receptor analogs or CKD, these drugs form the first line of therapy even before metformin is initiated. And then we mix and match as we go down. Of course, these slides are available in the internet, so we don't have to spend time on that. This particular lady is somewhere here. She already has micro and macrovascular complications, so the idea is to prevent the harm from worsening and going into end-stage disease and death. So the combination of empagliflozin and linagliptin, that's what I'm talking about, would allow 1.8% reduction in HbA1c. It significantly has pleiotropic benefits like weight and BP reduction. It has MACE and HF benefits and albuminuria benefits, as we already discussed. And of course, we know that they also have CV death and renal safety benefits. So the drug works, the drugs as combination works in all stages of the disease, but our idea is to stop this lady's progression from here to here. That is from micro, macro to end-stage disease and death. Empalina is available in our market as 10 and 5 mg and 25 and 5 mg combinations. And please be aware that though it is perfectly safe to use linagliptin irrespective of the renal or the kidney or the liver status, even in Child-Pugh C, empagliflozin should not be initiated below 30 milliliters per minute eGFR, though we can go up to 20 if heart failure is the problem. But third and SGLT2 inhibitors, which have proven heart failure benefits, which will decrease the progression of the disease. And a fixed dose combination, because pill burden has been consistently pointed out as an issue for Our Lady, so probably the fixed dose combination of empalina would be appropriate therapy for this patient. Thank you for your patient attention, and with the permission of the chair, we can take questions.
Thank you, Dr. Govinda. We'll take questions at the end of the session. We're running late. I'd like to call Dr. Krishna Patil for his lecture on holistic cardiorenal metabolic care in type 2 diabetes. Dr. Krishna Patil is a consultant nephrologist with KIMS and is had a fellowship in Ottawa University as well, and has a lot of papers to his name. Over to you, Dr. Patil.
To connect this. Will you connect it? No, they will connect it. This slide will be started. Okay. Good evening, everyone. Thank you, organizers, the chairpersons, and the audience for giving me this opportunity. My talk is an easier one now that most of it has been discussed.
I will be focusing more on the practical aspect with a hypothetical case, a pathophysiology of how the SGLT2 inhibitors work, especially the empagliflozin, a little focus on the evidence. So coming to this typical case, what we regularly see, a middle-aged female with diabetes of 10 years and diagnosed chronic kidney disease a year back with hypertension, dyslipidemia, and blood pressure of 140/90, ABPI of 0.8 in both lower limbs, hemoglobin 9, anemia has started, HbA1c 7.9, lipid profile, dyslipidemia is there, and urine ACR of 90, which is A2 or a moderate grade albuminuria, eGFR of 55, so she is already a CKD stage 3A, with a decline of GFR of 4 ml per minute in last 1 year, and a TMT showing myocardial ischemia during exercise. And she is on metformin, telmisartan, amlodipine, atorvastatin on best tolerated doses. So this is a typical scenario which we commonly encounter in our day-to-day practice. And what are our priorities in this patient? We see that this patient has some cardiac issues, renal issues, and underlying these two issues is the metabolic syndrome or the insulin resistance and diabetes, obesity or overweight. These are the background. So from the nephrologist perspective, I would like to highlight that as Dr. Jha sir had emphasized that CKD, the prevalence is not as it was thought. It is near to 17% in Indian adults, and of these 17%, 11% are with a normal serum creatinine. Only 6% are those with a GFR below 60. So just looking at the creatinine may not help us detect these CKD patients, especially in our at-risk patients, what we are discussing, the diabetics and hypertensives. So urine ACR needs to be included in our routine practice, especially in detecting these early CKD patients, because acting at that early stage is going to give us an advantage of decades in preventing landing on dialysis. Whereas once the creatinine has got elevated to 1.2 or above, that is when the GFR has gone below 60, then the advantage of postponing dialysis is reduced to years rather than decades. So it is very essential that we make it a habit to include urine ACR in our regular practice to detect CKD at the earliest, especially the ACR. The other point I would like to highlight about urine ACR is we categorize these patients of chronic kidney disease based on this heat map or based on urine ACR and the eGFR. So urine ACR does help us predict not only progression of kidney disease, but cardiovascular events as well. Even with a perfectly normal serum creatinine or a eGFR, or with a eGFR of 90 or 100, if the UACR has gone above 30, the cardiovascular events double. And when the UACR goes above 300, it becomes fourfold. The coronary events become almost 4 to 8-fold when the GFR drops below 60 with a UACR of more than 300. So measuring UACR and categorizing these patients or into risk categories is also very essential in our routine practice. So in this patient, there was a drop in eGFR of 4 ml in last 1 year. So measuring eGFR and the change in eGFR per year should also be highlighted, because a progressive drop of eGFR more than 3 or 4 ml per year predicts higher cardiovascular events. The substantial decrease in eGFR predicts that there is a 30% increased risk of major renal macrovascular events and all-cause mortality. Coming to the SGLT2 inhibitors, diabetic kidney disease, as we all know, diabetes the hyperglycemia or the increased, causes increased filtration at the glomerular level. And as we have larger fetuses in diabetic females, in the same way diabetics, even when the progressed kidney disease, the diabetic kidneys are enlarged in size. So it is the hypertrophy not only of the glomeruli but of the proximal tubules, which increases the proximal tubular reabsorption of sodium and glucose, and decreased distal delivery of sodium, giving the macula densa a sense of dehydration, causing a RAS activation. So hyperglycemia causing increased RAS activation, causing increased glomerular hyperfiltration related injury to the glomeruli, and the increased these leading to increased growth factors or oxidative stress at the tubular level, leading to loss of peritubular capillaries, hypoxia, and HIF resistance, leading to anemia. So diabetic CKD patients have an early onset of anemia at a better GFR as compared to other CKD patients. So when we start a patient on SGLT2 inhibitors and reduce this proximal tubular reabsorption of sodium and glucose, we are effectively helping the patient lose weight, lose calories, hyperglycemia management, and the increased distal delivery of sodium is giving the decrease in the RAS activation, leading to reduced glomerular filtration. So there will be a drop initially in the GFR of around 5, but better preservation of the GFR over the years because of decreased hyperfiltration injury or proteinuria. So if we look at the EMPA-REG outcomes, the evidence regarding empagliflozin improving the clinical outcomes in diabetic patients, we see a decrease in the systolic blood pressure by around 4 to 5 over 3 months, and an improvement in hemoglobin. Comparing empagliflozin to other molecules, the other SGLT2 inhibitors, as already emphasized by my previous speakers, they all have their benefits, but if we look at the EMPA-REG outcome and compare to the other studies, empagliflozin ticks all these boxes of reducing major cardiovascular events, cardiovascular death, all-cause mortality, hospitalization for heart failure, or CKD outcomes. So almost a 46% risk reduction in chronic kidney disease outcomes with empagliflozin. Empagliflozin used significantly improved kidney outcomes in the EMPA-REG study. If you look at when we risk categorize these CKD patients into low risk, moderate risk, or high risk and very high risk patients, we'll see that almost a 48% reduction in worsening of nephropathy with empagliflozin, and progression of macroalbuminuria can be reduced by almost 50%, especially in the high risk category, that is those with an UACR of more than 300 or a drop in or a GFR below 45. So empagliflozin resulted in almost a 68% lower odds of experiencing rapid decline in kidney function according to the EMPA-REG outcomes. This was in the if we look at the in the KDIGO risk category worsening or improvement in the risk categories, empagliflozin leads to a 30% reduction in the odds of worsening of the risk category and a 56% improvement in the risk category. Kidney outcomes with a different baseline UACR, the empagliflozin has shown 32% reduction in major adverse kidney events as compared to non-SGLT2 inhibitors. In different baseline eGFR categories as well, the major adverse kidney events have been reduced by 32% with empagliflozin use. Empagliflozin or any SGLT2 inhibitors, as we understand, they excrete glucose and have a tendency to increase excretion of water, so the tendency for edema is reduced by 56%. Risk of hyperkalemia, which is a major concern when we go on optimizing the ACE inhibitors or ARBs for reducing the hyperfiltration injury, that risk is less. The hyperkalemia in CKD3A is reduced by almost 50% by adding an SGLT2 inhibitor like empagliflozin. SGLT2 inhibitors and kidney disease progression in the different meta-analysis, they have shown a 38% relative risk reduction in progression of kidney disease. And so SGLT2 inhibitors, as emphasized in the previous all talks, now come out as the first-line drugs alongside metformin and GLP-1 analogs because of their advantages of weight management, hyperglycemia management, heart failure, progression, reducing the hyperfiltration injury at the glomerular level, reducing albuminuria, and preventing progression of kidney disease. So wherever there is choosing between these agents as first line, the GLP-1 analogs have more potent glycemic control as compared to the SGLT2 inhibitors. GLP-1 analogs have also shown better preservation of eGFR, better weight management, but with the concerns of cost and the tolerance, GI tolerance, they tend to fall back. SGLT2 inhibitors have become more common in our practice because of the not only the heart failure reduction and especially the for nephrologists, preservation of GFR, prevention of progression of macroalbuminuria, with little concerns of urinary tract infections, which we do see, and the mycotic genital infections. SGLT2 inhibitors are now the first-line drugs, which not only prevent progression of CKD, ASCVD risk, heart failure prevention, hospitalization due to heart failure, glucose lowering, hypoglycemia risk is less, weight loss, as canagliflozin is also being used at a higher dose for weight loss. With a 300 milligram canagliflozin, significant weight loss, almost like burning calories equivalent to half an hour of running on treadmill can be achieved with that kind of glucose excretion can be achieved with 300 milligram of canagliflozin. So SGLT2 inhibitors are now the standard of care in most of our cardiorenal metabolic syndrome patients. So the guidelines in 2022, the clinical endocrinology guidelines, they also recommend GLP-1 analogs and SGLT2 inhibitors with these benefits as first-line drugs. For nephrologists, for almost 2 to 3 decades, it was only the RAS inhibitors which were preventing the hyperfiltration injury and progression of kidney disease. In last 1 decade, the SGLT2 inhibitors have gained a lot of popularity, and now the third agent, the finrenone, is there to make a big change or difference in outcomes as an add-on to the other 2 standard of care therapies. So as emphasized in previous talks, lifestyle intervention, definitely that's the cornerstone, that's the beginning and the most important thing to do. But first-line drug therapies, SGLT2 inhibitor alongside the metformin, RAS inhibitors, moderate or high-intensity statins, these continue to be the first-line things, and add-on will be GLP-1 analogs, finrenone, and the other cardioprotective drugs. So the limitations with these, metformin, because of the lactic acidosis, below GFR of 30, we have concerns using it, and long-standing use also leads to some B12 malabsorption. SGLT2 inhibitors, risk of AKI is, we need to emphasize whenever we are starting SGLT2 inhibitors to a patient regarding the possible risk of AKI or drop in GFR that will be initially seen, which will eventually get neutralized, and they need to be emphasized about good hydration, especially giving a drug holiday during dehydration states or travel and during any infection, especially vomitings or diarrhea. Diabetic ketoacidosis, very minimal. Hypoglycemia, very minimal with SGLT2 inhibitors. GLP-1 analogs, I think cost is the biggest hindrance. We have not been able to use it, although it has shown such positive effects on kidneys and heart. So addition of SGLT2 inhibitors, the empagliflozin, to our prototype patient that we saw, the middle-aged female, it not only improves their glycemia, aids in comprehensive risk factor reduction, and prevents cardiovascular events and mortality due to progression of kidney disease. Thank you.
Thank you. Thank you. Because of shortage of time, we'll not take any question. Thank you so much, Dr. Krishna Patil. It was an excellent presentation. Now, I would rather invite, this would finish the Cardio Kidney Metabolism Symposium. We are inviting pharmaceutical quality talk by Dr. Kamini Desai. He is an head of the medical services at MSN Laboratories. Dr. Kamini Desai, she has 20 years experience in healthcare industry, in different pharmaceuticals in the areas of HIV, AIDS, allergy, asthma, gastroenterology, urology, and oncology. I welcome you.
Thank you, ma'am. Very good evening. Am I audible? Very good evening, and thank you for this opportunity. My esteemed colleagues today have been talking about the wide range of anti-diabetic drugs that are available in the market today, how to choose them based on available data and clinical experiences. And that is why I want to draw your attention to the concept of pharmaceutical quality and how that too is important in terms of improving disease outcomes, especially in the field of diabetology. So before I go there, quickly in the next 2 odd minutes, I would like to give you an update about the company, and this is pertaining to pharmaceutical quality. So we all know that MSN Labs has one of Asia's largest R&D center, which is here in Hyderabad, with more than 50 labs and more than 2,200 scientists working around the clock. We have managed to roll out more than 300 bioequivalent formulations for the industry, for the medical fraternity. We also rank number 1 globally in the number of DMFs filed, and the number is only growing. Our manufacturing facilities are spread all across India and also in the US. And all these facilities have more than 30 approvals from regulatory authorities from across the world. That makes us a world-class integrated global Indian company with our own R&D, API, and formulations division, systematically, because of which we are able to roll out one product at a time. I don't think there would be many companies who could boast of having their own APIs. So what makes us really unique is the fact that we are also led by Dr. MSN Reddy, who is a research chemistry scientist with particular focus on innovation, serving your patients better, and also improving the sufferings of Indian patients. With that kind of commitment to quality in mind, we have rolled out bioequivalent formulations, not only bioequivalent, but also first time in India, molecules in various therapeutic areas like pulmonology, cardiology, diabetology, onco, uro, even neurology, psychiatry, gastro, pain management, and even gynecology. So most of these molecules are also first time in India, which innovators never launched in our country. So like I said, the focus of Dr. MSN Reddy and his team, which includes us, is mainly on innovation, on patient improvement, patients' quality of life in India. That brings me to the topic of pharmaceutical quality. Now, when we talk about pharmaceutical quality, the determinants are various. Of course, the API is the most important component of any pharmaceutical product, but there is a lot more that goes into a pharmaceutical formulation or the final product. It is the raw materials, the excipients. It is the fact that every processing facility and equipment is different. And then comes the color, the coating, the packaging, the storage, all of which also decides the price of the product. So as far as the excipients are concerned, and this is the main objective of my talk, our excipients are sourced from world-class companies which have a reputation of having very stringent quality protocols. With those excipients, the APIs that we manufacture are of export quality and are exported to various locations outside the country. We also are the first ones to file drug master files and even ANDA applications, including our latest entrant, linagliptin. Once our API is formulated and the final formulation is ready, we also put it through bioequivalence studies to establish sameness or bioequivalence with the innovator product. So the latest armamentarium in our offerings to the anti-diabetic range has been linagliptin and dapagliflozin, and I will quickly through 1 or 2 slides take you through the bioequivalence data on these 2 new products. The objective, of course, has been to compare the pharmacokinetic parameters like area under the curve and Cmax, and also the safety parameters of these drugs, comparing it with the innovator. And we looked for the absence of a significant difference to the extent, the absence of significant difference in the extent to which the active moiety or the drugs that we are talking about reach the site of action when they are administered at the same molar dose under similar conditions, and when the study is systematically planned, keeping GCP guidelines in mind. So this is a quick overview of the bioequivalence and dissolution data of linagliptin and dapagliflozin. If you look here, the test product was our formulation, the reference was the respective innovator. The pharmacokinetic parameters numbers are close to each other, and when for statistical purposes, the log transform data is converted into a ratio of the test and the reference readings, it falls well within the 80 to 125% range, which is the mandated range allowed for calling 2 molecules bioequivalent. You will get a better picture here when the data was plotted in a linear graph where you get the reference and the test product ranges almost similar to each other, both for linagliptin and dapagliflozin. So through this bioequivalent data, not only did we establish that our molecules are the highest in quality and bioequivalent with the innovator, but in terms of safety also they match that of the innovator. With that, I would like to end my session with a warm invitation to all of you present here to come and physically, one-on-one witness the high-quality standards at our R&D facility, which is right here in Hyderabad. So in case anyone would, like to visit a manufacturing unit or R&D facility, you can reach out to any of our colleagues present here today, and we will be happy to host you. Thank you.
Thank you, Dr. Desai. That's the end of the session on cardiorenal symposium. It was an excellent symposium. All speakers spoke very well. And basically, they gave the message that the DAPA is for everybody, for cardiologists, nephrologists, diabetologists. Even now, I think it's being tried for prevention of diabetes and heart failure also, mainly diabetes. So the DAPA is for all. That is the message. Thank you very much. Thanks to the chairperson and co-chairperson.
Thank you.
So thank you, sir. I request all the speakers and chairpersons of the session to go to the selfie point for felicitation. And we begin next symposium of hormone and nutrition. I invite Dr. Arun Kedia sir, Dr. Seema Sunil ma'am, and Dr. Pratima Raj ma'am to come and chair the session.
excuse me guys, there's another addition to the chairpersons. I would like to call Dr. Aradhna Adipalli madam and Dr. Prabhu Kumar to please come upon the stage. Thank you. I think this
So, as we move towards the end of today's sessions, we begin the hormone and nutrition update. And the first speaker would be Dr. Manjula Anagani, and she would be talking on AI in gynecology.
Thank you all for having me here. But then, is it coming?
This is pointer.
That has to come, right?
This is pointer.
So like our chairperson said, coming to the end of the session, but definitely we are not talking about the end of whatever is going to happen. We heard Dr. Alok speaking about the AI, and here I am talking about AI in gynecology, and let us understand, for any technology which comes into the thing, it's always a latent period, and then comes the accelerated phase. So is AI in the accelerated phase right now, or in the latent period where we all want to understand? Can I have a hand mic? And can I have a slide changer? Like I always say, we are all the restless people on earth, which we do. Like everybody says, it is a potential to revolutionize everything, to give accurate diagnosis, treatments, and improved outcomes. Like Bezos says, it is to make it available for everybody in the way we want. So let me actually understand, what is our understanding and expectations, and it's going to be true, or is it something what we know? We know that AI is going to give guidance according to what we are going to feed it. Is it possible in the, can I have a mic which is hand mic? In a gynecology, imagine a situation where an unmarried girl had 2 abortions, full stop, over. She's married, no history is being told. Now prediction of cervical incompetence in the first pregnancy. 2 abortions itself, and something which we make iatrogenic is definitely has a higher risk for Asherman syndrome plus cervical incompetence. So before we jump and say AI is here to stay, AI is definitely going to be there, let us understand the other side of the mirror, that is the human error. So that's where we are. So is it the alternate intelligence or the artificial intelligence? And it's medical engineering where we call everything comes together to make the situation where we are in. So is it only going to take evidence, or are we going to put some more experience into it and understand what not to write into it, what we write? Because in our OP, we write in a corner, unmarried girl in R relationship. Then we know we can expect a sexually transmitted disease. I cannot put all that into thing because the data is out there to stay, and we are still working on the cyber security of the data. Plus, we are also talking about ethics of what to say, what not to say. So when we come to this, medical challenges, we know they're huge. Is it going to be solution? Finally, whatever we do, any innovation we talk about, it is for the safety of the patient and comfort for a surgeon. So is it where we are? So when I say me, Dr. Alok spoke about human and AI. Here I wrote me, because I am also called as one of the computers because I have a .com brain. Once I see somebody, when I talk to them, I never forget. So what is the difference between me and AI? Because I feel I'm immune. I feel I'm the best. I don't have to do AI. I will do everything myself. But the important point is, can it cut short my wasting my brain and my time? So the difference definitely would be intuition, gut feeling, and years of experience, but memory can be a boon and a bane. So these are all the best part which comes, but in OP, like I said, in a gynecology, it's a bane. So we have to know where to use, where not to use. In IP, yes. But in OP, in gynecology, please don't think we are going to get the data into it, because what we are feeding, what the patient is feeding might not be true. Let me give you another anecdote. We will have a girl with Mullerian agenesis. Means she's born without uterus, without vagina, without cervix. Now they're married, she comes after marriage, and the first thing the family is going to tell me is, she had regular cycles before marriage. After marriage, cycles have disappeared. Anatomically, we know there is no vagina, there's no question of her having menstrual cycles, but no. And we are not here to break her marriage, nor are we here to tell that, no, it cannot be true. So the sensitivity starts coming in there. That's where the human part comes, where we say, probably she must have had infection after marriage, probably it's closed there. So let me first correct it. So we create neovagina, see that she's sexually normal with her husband. So all this is not going to come out of AI because that's not what we are feeding into AI. So when it comes to medicine, we know the importance of drug discovery, telemedicine, patient data security, how to use it, open access efforts, analysis. But very important is the ethics concern and the regulatory considerations which we talked about, which is going to be very complex. So in gynecology, we have very few places where we use. It is very useful for us. One is definitely to improve the diagnostics and personalized treatment. That is in the medical imaging to detect the abnormalities, when to operate, when not to operate. Like again, in coming into the Mullerian anomalies, if it is septum, we operate. If it is bicornate, we do not operate. So do we need a laparoscopy to diagnose? So do we have an AI which can predict what is the truth? Then the AI predictive analysis to identify the patients at risk because of the DNA and genome mapping which we are having now, and streamlining the administrative tasks and improving the outcomes. But for me, as a surgeon, it is in the surgery which made a huge difference for the outcome and the precision of the surgery which it comes. So we are looking at wearables, just like any other general medicine like CGM or blood pressure, but I'm still waiting for something which can tell the electrolyte imbalances so that we can pick up very fast and treat very fast. So imaging is here to stay. There is no doubt about it, where we talk about CT or MRI or ultrasound, 3D picture, and then how we come out with it. Labs, perfect. We are okay with that. Monitoring is where it becomes difficult in the OP of when in gynecology. Real world data is yet to come, much more to come. That's where we are doing virtual health assistants, bots are here, and yes, but patients should not get confused between the real chatbot versus the real doctor. That's where it is. So personalized ops, but robotics made a huge difference in gynecology. So ultrasound, fetal anomalies, yes. Mullerian anomalies, yes. Ultrasound imaging classifying anomalies, and mammograms, interventional radiology, where simulating minimally invasive procedure. Nowadays, we are not having cadavers. We do know that. We are not getting trained in that. So procedures, we do not have patients also for us to keep on experimenting on the patients. So procedures, simulators are here to stay, and we do them, we learn them by the feedback mechanism of the simulators. And BMD will definitely analyze this. So these are all the things which we look at. So these are the few pictures I would like to show. So here we see the Mullerian anomalies. And this is the thing. Here you know it, okay, E is where septum, she will do very well and I do a septal resection. The same picture, if you look at here, A, she doesn't need any septal resection. So AI is going to tell that which patient is going to do well, and the 3D reconstruction of that is going to be there. But the huge difference again will come in the fibroid mapping. Fibroid mapping is something which makes a huge difference in the preoperative, postoperative outcomes in the form of for even IVF, plus predicting me about how many fibroids can I actually remove and how many it is better to leave it so that I do not destroy the function of the uterus. So these are all the things where we look at. So predictive analysis for care, identifying at risk, this is something which works for every other medicine. How do we predict whether whatever we have written, considering that the human error is not there and that is what we are going to enter. And then the personalized care. This treatment comes in care with PCOS, which is increasing a lot in today's time because of the environment and the stress which we are giving them. So that helps us in knowing in a genetically preponed case, like we know that fibroids are more in the African countries, next is only India. When we take endometriosis, we know Calcutta has the highest, then again South India has the second highest endometriosis, worst case of DIE and stage 4. So when they're genetically having a thing, then the lifestyle, environment, and the family, then we know which patient is predicted to go in for recurrent endometriosis with the genetics, which might not go, and where the post-operative medical treatment management is not necessary. So consider the individual patient factors and preferences in what we are going to give and the treatment for that. So in surgery, because as a surgeon, like I said, we all look at how am I going to benefit from it. Yes, First is definitely technique. Like I said, simulators are here to say whether you want to do a good ultrasound picture in the angle, that is simulator. Whether I want to do an operation TLH, I would be operating on the simulator and see. There will be feedback of bleeding coming in. It might not be real, but it will really tell me when to stop, where to stop. Technology is incorporating into it, enabling the faster, cost-effective thing. That's where robotics are here to say. Robotic surgery is where technology has been incorporated. It gives me back my feedback. And intraoperative analysis and prediction even during the surgery, telementoring during the surgery, where Proximi is here, where we talk about somebody else who is there in US actually looking at my surgery here going on, and when I am stuck, they can actually do. This was when 20 years ago, we were still discussing about it. Today, it is a reality. Feedback, research, publications, yes. Auditing of the techniques is suggesting the steps for better outcome. What do I mean by that? So this is the robotics which I'm talking about. We have the systems in place, and this is where the whole AI comes into place. See, this is where simulator, this is how the simulator looks like, where we start learning the technique, how to operate before we operate on the patient in the simulators, then the cadaver, then comes the actual surgery. So actual surgery, we are only operating on the console where everything is AI based, and there is here the touch, the control pad through which I think this I don't know if this is working. Onto the right of my hand, you have the control pad where I can control which hand works, which hand do not work, which leg works and do not. So this is how the arms of the robot is going to work. So in all of this, the most important is this recording thing, the video and analytics platform, where the touch surgery enterprise is completely AI. It is the iCloud based, where it connects the OR to the cloud, where it can access, analyze my videos. So how am I going to do? So one video here, let me run it. So to shell us, it will tell me if I'm doing the exact way, the energy precision. So this, if you can see the robotics, the hand with which it goes, this everything is done through the thing. And you see how exactly the lateral thermal, it predicts what is the lateral thermal damage, the chance, the type of surgery I'm doing. So what is it going to be my complication rate, and how is it that, how precisely or correctly I am doing it. So it helps me in self-auditing and this. So if I show you here, sometimes I'm my own best judge. So if you can see here, the surgery is going on there, and I can tell, oh, this step I did not do well. I go back and check it up. Then I will need a peer to work on it.
Excuse me, you will have to hurry up.
Yeah, 2 minutes. So AI and touch surgery is here to improve that, and that's where we are. In obstetrics, we have the fetal monitoring, and DNA analysis is here to stay. Like I said, we have genome patries everywhere, identifying the gene mutations, how it's going to come out with it, precision medicine, and administrative tasks. But ethical considerations are something which I already spoke about, the privacy issue, and gynecology, it's a huge thing which we need to be done. And finally, there are so many domains which are available and so many things which are used, but the Internet of Medical Things is one which happens in real time, which Dr. Alok has showed, where it revolutionized, but again, privacy challenges are there. Data sets are available, but chatbots, but the doctors have to know the chatbots are not, patients should know they're not substitutes. For the future, there's huge things to do. How can we address the bias and integration into the thing? Lot of things are there for the future. To conclude, it is essential to ensure that AI applications in gynecology is there. Emphasis on transformative potential, encouraging for that. AI is not going to replace doctors. Remember that. It's only going to be getting more jobs to the doctor who knows how to use AI. So we are going to learn AI so that it can be utilized properly. So artificial intelligence, let it be safe in the hands of ethical doctors. And like I always say with any technology, first they ignore it, next they laugh at you, and then they fight you, and finally we are the ones who will win. And early users are always get the best outcomes. So AI, yes, latent period is still going on, but it is here to stay. Thank you for having me here.
Thank you, ma'am, for the best informative session in the workshop. And due to paucity of time, we'll take the questions at the end. And now I invite Dr. Ataullah sir to speak about on gut microbiota, impact on diabetes management and role of acarbose. And I feel blessed to invite my teacher onto the stage.
Is it okay? Working, yeah. So I'll try to give you an overview about the gut microbiota and what's going to happen in future, because this is a field which is having an intense research, and you will be hearing about gut microbiota in the days to come, and the research will be more and more oriented in the coming decade towards the gut microbiota. And how the anti-diabetic drugs which we use in our practice affect the gut microbiota, and what are the available anti-diabetic drugs which can influence the gut microbiota in a favorable way. So these are my disclaimers. So overview, I'll be taking you through the gut microbiota host homeostasis, effects of dysbiosis. Dysbiosis is nothing but imbalance between the good and bad bacteria. Not only bacteria, we also have the viruses, we also have the other agents. So role of gut microbiota in dysbiosis and diabetes pathophysiology, how gut microbiota influence the onset of diabetes, and role of acarbose, the alpha glucosidase inhibitor, which we commonly use in our day-to-day practice, is going to impact the treatment of patients with type 2 diabetes mellitus. Now this is how I'll take you through. So you have so many gut microbiota, the number of which is equivalent to the number of human cells in the body. So what these microbiota do is they produce these small chain fatty acids like acetate, propionate, and butyrate, and they help in proper functioning, motility, and integrity of GI tract. They improve the glucose homeostasis, enhance satiety, and also the synthesis of branched chain amino acids, which is responsible for appearance of insulin resistance, and also metabolism of bile acids, which take care of the carbohydrate metabolism, lipid metabolism, as well as regulation of energy. And also they have other properties. So it co-evolves and symbiosis with humans and combating pathogenic microbiota. They assist in nutrient digestion as well as maintaining the integrity of the intestinal epithelia and promoting the immunological development, because diabetes is said to be a disease where there is a slow onset of slow and ongoing immunological inflammation. Now, when you look at the types of gut microbiota which we commonly see in the body, the composition approximately 80 to 90% of them belong to two categories. One is Firmicutes and number two is Bacteroidetes. Firmicutes dominate the gut microbiota composition of healthy individuals. So Firmicutes is good for health, while Bacteroidetes can favor inflammation by disturbing the gut epithelial cells barrier function. So we need more Firmicutes and we need less of Bacteroidetes. And actinobacteria, of which Bacteroideum species is another one, contribute to producing butyrate along with Faecalibacterium, Eubacterium, and contributes to healthy gut. So maintaining diversity in gut microbiota is essential for a healthy living. Now, what are the factors affecting gut microbiota in healthy individuals? So we have the human gut microbiota composition, which varies because of the eating habits, because of individual differences, and because of the age also. And by the age of 3, your gut microbiota becomes stable, and at maturity, Firmicutes, Bacteroidetes, and Actinobacter become the dominant gut microbiota in healthy individuals. And Bifidobacterium tends to decrease in older adults, while Clostridium tends to increase. Now, if you look at the effects of healthy gut microbiota, dysbiosis on the gut and metabolic pathways, on the left side you can see the healthy gut microbiota, what they can do, and the right side you can see the dysbiotic gut microbiota. So these are what we call as symbionts, which are helpful, and pathobionts, which are dangerous for us. So healthy gut microbiota, they decrease the gut permeability, they decrease endotoxemia, they decrease pro-inflammatory cytokines, and there is benefit as far as the production of small chain fatty acids as well as the indole acetic acid, and also there is increase in the insulin sensitivity, ultimately because of also the other factors like the healthy diet and lifestyle and prebiotics and probiotics. This leads to improved gut metabolic health. Whereas if you look on the other side, the pathobionts, they increase the gut permeability, there is slow onset of endotoxemia, pro-inflammatory cytokines, increase in adiposity, increase in insulin resistance, so on and so forth, and along with consumption of high fat and high sugar diets lead to metabolic diseases and type 2 diabetes and cardiovascular diseases, as well as the inflammatory bowel disease. Now, this is how it can happen. Diseases caused by gut microbiota. So there are so many diseases which can occur. Type 2 diabetes is one among them. Obesity is one among them. Metabolic syndrome is one among them. Now we are also looking towards the metabolic associated fatty liver disease. Previously, it was called the non-alcoholic fatty liver disease, the terminology of which has been recently changed. And imbalance of microbiota is defined as repetitive or prolonged deviation from optimal microbial homeostasis and cause the loss of self-tolerance and spread of effector cells in pro-inflammatory signaling. Now, this is the immune and metabolic disorders play a very important role in the pathogenesis of type 2 diabetes mellitus, and microbiota dysbiosis is seen both in type 1 as well as type 2 diabetes mellitus, and these can lead to gut leakiness, and which further leads to antigens uncontrollably entering the circulation, and these cause activate the islet autoimmunity, in turn leading to damage to the beta cells of the pancreas. And this is through a picture depiction of how the healthy individuals have the endothelium which is tightly built together, whereas in case of the bad microbiota present in the stomach, we have gut leakiness where these antigens go into the circulation and damage the pancreas and all the other areas. So the metabolic endotoxemia leads to activation of insulin resistance in muscles, liver, and adipose tissue and hypothalamus through activation of TLR2 and 4. This in turn leads to impairment of insulin signaling. So these have got an important role as far as the insulin sensitivity is concerned. Now, the dysbiosis leads to a decrease in butyrate and increased permeability, changes in bile acid pool, as well as a decrease in branched chain amino acids will ultimately lead to impairment of beta cells, low-grade inflammation, as well as insulin resistance, ultimately leads to the development of type 2 diabetes mellitus. So environmental factors play an important role in the onset and development of type 2 diabetes mellitus, and the recent data has shown that gut microbiota dysbiosis is extremely important. Now, it's not just the gut microbiota which is responsible for all these metabolic diseases. There is a complex interplay between the genes, the environment, diet, and the microbiota, ultimately leading to the present-day metabolic diseases like obesity, insulin resistance, type 2 diabetes, and metabolic syndrome. So there is a complex overlay of all these factors. Now, this is a study which has shown that what happens to the gut microbiota in patients with type 2 diabetes mellitus, and this is a recent metagenome-wide association study showing that the patients with type 2 diabetes mellitus were characterized by having a moderate degree of gut microbial dysbiosis. There is decrease in abundance of some universal butyrate-producing organisms and increase in the opportunistic pathogens like Clostridia. And this is a study from the cardiovascular research which has shown that even gut microbiota are also responsible for cardiovascular diseases implicated in atherosclerosis, thrombosis, blood pressure homeostasis, myocardial ischemia,